Hi everyone and welcome to the Latte Lounge. I'm delighted to be joined tonight by Mr. David Gordon, who is a consultant orthopedic surgeon, foot and ankle specialist. We're going to be here for about half an hour and we'll be taking questions at the end. So welcome David, thanks for coming in tonight.
Hi Katie, thank you for having me.
Oh, it's a pleasure. Now listen, before we start, I thought I'd give everyone a bit of background information about you, if that's okay.
Sure.
So, as I said, David is a consultant orthopedic surgeon practicing at the London Clinic, Spire Bushy Hospital and Spire Harpenden Hospital in London and Hertfordshire. He's one of the UK's most experienced bunion surgeons, specialising in a minimally invasive or keyhole approach to surgery, which offers minimal scarring, reduced recurrence rates, and a faster return to work and normal activities. He performs bunion corrections as day surgery under either general or local anaesthetic. And what's amazing is that most patients don't experience pain after surgery, so there's no need for feet to be in plaster. And in addition to bunions, he sees patients for the full range of foot and ankle conditions, many of which he treats using minimally invasive techniques. So, wow, David, let's go back to, as I call it, Biology 101 first. Maybe the best thing we can do is if you can start by talking to us a little bit about the bones, the joints, the tendons in our feet, and what we actually need and use them for, and what happens, to our feet as we age.
Absolutely. Thanks, Katie. Thanks for the introduction. I know it's a bit of a mouthful, minimally invasive, isn't it? The feet are a kind of a wonder of engineering, really. And Leonardo da Vinci quoted and said the human foot is a masterpiece of engineering and a work of art. And it really is when you learn about the anatomy and its function. So there are 28 bones in the foot, 33 joints, over 100 tendons, muscles, and ligaments. So it's an incredibly intricate part of the human body in terms of anatomy as well as function. So what does it do? Well, we can balance on our feet. It propels us forward. It can also act as a shock absorber as well. And, we can play sport with our feet. What's fascinating about it is it can be both soft and hard, the foot. So when you bring your foot forward while you're walking, it's actually soft, so it can absorb the shock of the force and the terrain of the ground. And then it can stiffen, and that allows you to have a rigid propulsion off in forward motion. So it's got this adaptability. And all those tendons have to work very hard in millions of cycles over your lifetime to do that. And that's where, unfortunately, as time goes on, problems start. What's interesting about the foot is when you're born, it's actually, most of your skeleton, in fact, is mostly cartilage. And over time, it goes through this process of ossification or bone formation. So you start off with cartilage and then it forms into bone. And as that develops, the foot shape develops as well. And your arch starts to develop around the age of 4 or 5 as things start to stiffen up. But you often have flat feet when you're a child, and then the arches develop around that time. And then they stop growing, your feet. Girls about 13 and boys about 14. And then things actually completely fuse together by the age of 16. So it's quite unusual to get foot problems when you're young, when you're flexible. But there are a few conditions that you can get around the age of 7 to 13, as you have start to have these growth spurts where things start to stretch quite rapidly. Things like the Achilles tendon and the plantar fascia. And those problems then go away, but then they kind of bite back at us in our 40s.
Yeah, we have a lot of questions actually, which I'll go on to in terms of plantar. I can never even pronounce it.
Plantar fasciitis.
Right, there we go, fasciitis, got it. Actually, we have a blog on our website about that. So what happens? So obviously, when we're younger, we're more flexible. What actually happens when we sort of hit 40? Is it to do with our hormones or our makeup that sort of these problems start, or is it more to do with lifestyle?
There's sort of two categories, as I put it. One, almost set in stone, they're your genetics. So things like bunions, things like arthritis. And there are other things which are lifestyle, which are due to aging effectively. So, and overuse, particularly tendons. And although the plantar fascia isn't a tendon, it behaves a bit like a tendon. So that's why it's such a common problem when you hit your 40s and beyond. I mean, 1 in 8 people will experience an episode of plantar fasciitis in their lifetimes. And then you have other things like the Achilles tendon. And both the plantar fasciitis and the Achilles tendon are often overuse issues. So that's kind of a problem with the adaptation of that tissue, where people do a bit too much than the tendon can adapt to. And as you get older, the tendons have a poorer and poorer ability to adapt. So, you know, if you're a 20-year-old and you want to go off and do a 5-mile run, you might be pretty puffed, but your tendons will hold up. If you're in your 40s and you do that, then they're going to start screaming and shouting and saying, no, that really hurts, because they don't have the ability to repair themselves in the way that you did when you're 20. And that's why you have to be really careful when you are doing those sorts of activities or want to start those activities. You've just got to ease yourself into them much more carefully than you did when you were, when you were in your 20s.
Yeah, absolutely. So let's talk about some of these sort of common conditions you see. I mean, obviously we're a women's only group, but there's a lot of women who, like me, my husband's always got problems with his feet. So let's talk about the sort of common conditions you see both in men and women, and then what treatment options they are for all of them. So maybe we'll start with, you talked about the Achilles. Let's start there and then, move.
Yeah.
Yeah.
The Achilles. So the Achilles is the biggest tendon in the body. It joins your calf muscle to your heel. And when you're walking or running, huge forces are going through that Achilles. So if you're running, it can be up to 8 times your body weight. So, big forces. And one condition that the Achilles causes a problem with is something called tendinopathy. There's lots of different terms: tendinitis, tendinosis. The true term is tendinopathy. Effectively what it is stiffness after a period of rest. So you wake up in the morning and you're hobbling, a bit like you would do in plantar fasciitis, but the location of the pain is different. So you get stiffness, you get pain on activities, and it can be after an activity, and when it starts to get a bit worse, it can be during an activity. And you can also get a lump around the Achilles as well. So the first thing, if you were to get discomfort, either stiffness or pain around the Achilles, the first thing to do is stop what you're doing that's probably aggravating it. That tendon hasn't had enough time to adapt to the forces that you're putting through it. Don't push through the pain. All that will do is make it worse. So stop what you're doing and seek advice. And either come and see a good physiotherapist or come and see someone like myself, because you need to have an assessment, confirm the diagnosis, and often an ultrasound is good for that, to visualize the tendon, to check its integrity. And then most of the treatment is non-surgical. It's about rehabilitation, physiotherapy, and there's also a treatment called shockwave therapy, which works really well as well.
Okay. And what about the plantar fasciitis?
Yes. Yeah, plantar fasciitis is, as I say, it's one of the most, after bunions, which 1 in 4 people have bunions, believe it or not, 1 in 8 people have plantar fasciitis. And it is a real misery. It really can be. I call it the box of tissues condition, because there's only one time when I need to have a box of tissues in my clinic, and that's for someone who's got plantar fasciitis, because it can literally put a pause on your life for 1 or even 2 years. It can be very, very debilitating, particularly if you have it in both feet. It is a horrible condition. So it really is worth treating it with respect, even if you have a small amount of heel pain, worse first thing in the morning, or again after an activity, or even during activity. Whatever you do, don't push through the pain. Stop what you're doing, seek advice. And again, physiotherapist or someone like myself. Ultrasound again to look at to confirm the diagnosis. And what it is, it's this random degenerative condition in this band of tissue under the sole of the foot. So it goes from the heel to all the toes. We don't quite know why it happens. But you get this degeneration, and it's really painful, and you get a thickening of the plantar fascia. You can still walk around and do, the plantar fascia functions normally, but it's really painful. So in terms of treatments, first of all, modify what you're doing, modify the activity that might have exacerbated the problem. And in lockdown, I've just seen a huge spike in conditions like plantar fasciitis, where people think, fantastic, normally I do a sedentary job, I'm just sitting at my desk and now I've got all this time, or, I'm going to do some walking, that's the only exercise I can do. And people haven't been walking 5 miles a day every day when they're in their working lives, and now they are. And the tendon just hasn't adapted. So the plantar fascia will start to hurt and cause or trigger a degenerative process. So just, first of all, stop what you're doing or change the type of thing you're doing. So cycling would be a great thing to do as an alternative rather than walking or running. And in terms of treatment, what you want to do is retrain the plantar fascia or the Achilles tendon as well into how it can handle those forces. So we do certain types of physiotherapy with certain types of loading, and this treatment called shockwave therapy, which works really well. But shockwave therapy is painful to have. So it's a 3-minute treatment, which causes 6 or 7 out of 10 pain. After the treatment stops, you don't have pain associated with the treatment. You normally have 3 to 6 sessions spaced a week apart. But it's a very evidence-based and successful treatment. So you do have to experience some pain in the treatment, but it does work, and it's certainly much better than living with the pain of plantar fasciitis.
Gosh, wow, yeah, no, they say no pain, no gain. I used to see a lot of people with a tennis ball and being told to sort of, is that?
Yeah, there's lots of adjuncts to treatment of plantar fasciitis. So you can get a frozen can and roll that underneath the arch. You can get knobbly balls or a tennis ball and stretch the plantar fascia that way. And also wearing a night splint. So when you wake up in the morning, things have been all relaxed and contracted. You go and put your foot down and things stretch. And that is really, really painful. It takes about 10 minutes for things to warm up. So you can actually wear a splint at night that keeps your ankle at a sort of a 90-degree angle and the plantar fascia stretched. So when you get up in the morning, things are already stretched and not so sore. The only problem with night splints are I've not met many patients who could sleep an entire night with a splint on. So they can be a bit uncomfortable, but it is certainly worth trying. And the other thing for plantar fasciitis is silicone heel cups. So a nice squidgy heel cup that goes inside a shoe. And if you wear a trainer, a really nice well-cushioned trainer as part of your footwear, rather than something firm, that can also be really helpful.
Okay, someone's just put on the group, can you do anything to prevent it?
So yes and no. Some people just get de novo plantar fasciitis out of nowhere. Can't explain why they've got it. It's not related to anything in particular. Other people, it's an overuse trigger. So, for example, like I mentioned, lockdown walking or a new activity. If you like to stretch and have that in your routine, like you do yoga, for example, it certainly can't hurt to build in some plantar fascial stretches as well as calf stretches, because there's an association with a tight calf and plantar fasciitis. So general stretching of the plantar fascia and the calf. But to be honest, I don't think there's any good study that has proven that doing those stretches would prevent you from getting plantar fasciitis. But it would make sense that it could do. Yeah. It's a difficult one. It's a bit potluck.
Okay, well, we're gonna move on. So talk to us about bunions. You're called the bunion doctor, very glamorous, but it is, in all seriousness, it comes up all the time in our community. And I'm curious, is it because we're all, we in the 80s we all wore a lot of high heels, or is it much more to do with genetics?
Yeah, there's a huge footwear myth surrounding bunions. Almost certainly not due. You don't get bunions due to your footwear choices, almost certainly. Tribes in Africa who don't wear shoes, they get bunions. There's generally a very strong family history. So in my patients, I'd say about 80% of my patients, when I ask them, because I ask every patient if there's a family history, and there's normally one or second generation who've a member of the family. I've got one patient whose mother and 5 aunts all had bunions. So In fact, I was looking at my dad's feet the other day, and he's got a small bunion, so I'm like constantly looking at my feet now. So it's one of those things. It's, you know, clearly footwear, a heel, a high heel, and a narrow shoe. If you've got a small bunion, it's going to make it more painful.
Yeah.
Not necessarily going to make the bunion worse, but clearly it's going to increase your symptoms if you wear that kind of footwear. So we all know, you know, women generally like to wear lovely shoes, narrow, high-heeled shoes. So, you know, it's not going to give you a bunion almost certainly, but it certainly, if you had a slightly wider or a small bunion, it will make symptoms worse. Mm-hmm. So, yeah, absolutely. 1 in 4 people have bunions, but that's not to say 1 in 4 people will ever need surgery. It's clearly much, much lower than that. So the things you can do to avoid an operation, it's all about your footwear. So look at the sort of shoes that you're wearing. So generally wider, softer footwear, something that's not going to squeeze the foot, and will be a really good starting point. There are splints, and splints abound. If you look on Amazon and you type in bunion splint, there's a huge array of all sorts of a whole menagerie of different types of things. There is no proven splints that can reverse the bunion or stop it from progressing. So in my experience, I don't recommend bunion splints. I do recommend spacers that go between the first and second toe, because when the big toe pushes over onto the second toe, it can be painful and can cause a corn or a callus. So to relieve that specific symptom in between the first and second toes, a silicone spacer is a good thing. But again, it's not straightening. Yes, it's straightening the toe temporarily while you have the spacer in there, but it's not going to reverse the bunion in any way. Also, there's no exercise that's going to reverse your bunion either. So ultimately, once you get to the stage where you've altered your footwear, but you've reached the point when that footwear is not appropriate for your lifestyle, whether it be work or social, you know, it's a lifestyle choice what footwear you want to wear. But if you feel you can't fit into the shoes you'd like to wear because of your bunions, and you're getting regular symptoms with pain on the bump on the side of the foot, and that's the time to start thinking about whether you might want to have a keyhole solution to cure your bunions.
So on that subject, talk to us about this non-invasive treatment that you specialise in. I mean, it sounds so much better than having your foot in plaster for weeks or after. So
so traditionally, people used to be put after surgery for bunions, you'd be in plaster, you'd have crutches, you'd have a 6-month recovery, you'd have a big scar along the side of your foot. But things have evolved so much so now that the way I do bunion surgery is keyhole. So you have a few very small incisions on the side of the foot rather than a really large cut. I don't need to open up the joints, which can cause stiffness that you would do with open surgery. So it's away from the joint. And I use specialist instruments to fit in those little incisions. And I use X-ray control throughout the whole operation. So I'm looking at how I'm cutting the bone. I'm looking every step of the way. Whereas with open surgery, you directly visualize. So with this new technology, you don't have to have all this soft tissue stripping and you know, opening up the foot. It's all done just by bone cuts pretty much. And then you fix the bone with screws. So you're actually moving the bone back to its original position where it was, you know, that many years ago. You're not just shaving the bump off. You actually have to anatomically move and correct. So you get a really good anatomical correction of the foot, which lasts. And because you've not had this big dissection, it's all through keyhole, then you can get going a lot quicker than traditional open techniques. So a typical patient for me, if someone's in their 40s or their 50s, you know, it's day case operations. You go in the same day. You have a choice of anesthetics. You can either be put to sleep if you don't want to hear or see anything, or you can be wide awake, or something in between like sedation. And you have an injection around your ankle called an ankle block as well. So your foot is numb throughout the procedure. And then when you wake up or are more conscious, you have a completely numb foot. So you normally don't have any pain. And most of the time when you get home, that block wears off, all that significant pain has been masked by the block, so you don't normally have significant pain, you know, after surgery. You do need to have a little bit of time at home. I recommend 2 weeks, just elevating the foot. But you can walk around, you have a surgical sandal, you can, you know, walk around room to room, you don't need any crutches, there's no plaster. Just elevation is important for the swelling and for the healing. And then I see my patients at 2 weeks. We check everything. They go back in that sandal, and the sandal can be worn for about anything from 4 to 6 weeks, depending on exactly what I've done, and then into a comfortable trainer after that. So between 4 and 6 weeks, a comfortable lace-up trainer because they have a little bit of swelling. So you could theoretically get back to a desk job after 2 weeks, depending on what your commute's like. A more physically demanding job, a long-standing job, it's about 5 or 6 weeks. But it depends a little bit on the patient, the age, the bone quality, and a few other factors.
Yeah. Well, I mean, it sounds so much better. I'm just having a look down because there's a few questions come in, and so Tanya Stoll has said, I've got, I think, plantar fasciitis on the sole of my foot. It's a bulbous lump, exactly from, I think, what you said, walking miles during lockdown. It's not really painful, but I'm aware of it. I've been wearing the bands around my foot with a pad in the sole. Is there anything else? She also says sometime, oh no, this is another person. So we'll answer that one quickly and then, yeah.
So thank you for the question. The plantar fasciitis, when you look at the foot, it looks and feels normal. So if you've got a lump, it's almost certainly not going to be plantar fasciitis. You've got a bulbous lump, I think you mentioned. Yeah. It's worth getting that checked out. Almost certainly not going to be anything to worry about, but if you can feel a lump, there are things called plantar fibromas, which are little scar tissue-like lumps in the plantar fascia, so the same structure but slightly different area and a slightly different condition. Or it could be something else. It depends where the location is. So plantar fasciitis is plantar heel pain. So if you imagine my hand is a foot just at the base of the heel underneath, not by the base of the toes, but at the base of the heel. So I'd recommend, get an opinion, probably an ultrasound or some form of scan to have a look at that. Yeah, but don't worry.
No, and Tanya, what we'll do is, and we've got a few other questions. I'm going to leave the rest of the questions till the end, and if we don't get through them, I'll forward them on to David, and we'll get some sort of generic replies. Obviously, David can't give personalised consultations via email, but we can give some generalised advice. Let's just talk through very quickly a few other conditions that you see. So you were telling me, I think, you see people with toe deformities and Morton's neuroma. So give me some examples of what both of those are that you see and what you can do. Yeah.
So probably the third or thereabouts commonest condition I see is something called a Morton's neuroma. And that's a normal nerve under the sole of the foot which gets irritated by ligaments around the balls of the toes. And that irritated nerve starts to become really painful. So the symptoms are pain on the sole of the foot around the balls of the toes. It can be feeling like I'm walking on a stone or a pebble. The pain can radiate into the toes, and commonly the third or fourth toes, but sometimes the second and the third. But visibly, it looks completely normal. There's no kind of toe deformity or there's no lump to feel, but just really, really sore. Walking on hard floors would make that worse as well. High heels, narrow shoes also make it worse. So it's a common condition, and an ultrasound is normally used to diagnose it. And I would start off in terms of treatment to try and avoid an operation. And often an injection, a steroid injection, using an ultrasound to guide it very accurately into the area is the first point of call, coupled with maybe an insole, so something can go inside the shoe to relieve the pressure of the nerve. Often, however, those treatments aren't successful. So a very small operation, a 10-minute operation to remove the nerve completely has excellent success rates, and it's a week at home with your foot elevated and you're kind of getting back to more normal after that.
Okay, and toe deformities, what I mean, sounds like the Chamber of Horrors. Yeah.
There are a myriad of different toe deformities that but I mean, a common toe deformity would be a hammer toe. So if your toe's like this, that's a hammer toe, commonly in the second toe, and very commonly associated with a bunion, because the bunions change the mechanics of the foot. So the bunion is not a growth of bone on the side of the foot, it's actually a swinging of the bone inward. And it changes how the body weight is transferred onto the foot. And often it gets transferred onto the second metatarsal, the second bone within the foot. And then that joint starts to get inflamed, painful, and distorts. And the distortion can be an elevation of the toe, very, very subtly initially. And then the toe can elevate, and then it can actually bend and become a hammer toe. And that's driven by the bunion. But also you can get, without a bunion, the same problem. And so people with a tight calf, for example, or a high arch, will load the front part of the foot more preferentially, and that second toe joint becomes inflamed and distorted. There are other things like bunionettes. That's called a baby bunion or a tailor's bunion, which instead of having your big toe with the bump on the side, it's little toe with the bump on the side. That's quite common as well, and that's treated in exactly the same way as bunions are. Footwear choices and then keyhole surgery. Other toe deformities, well, you've got mallet toes, hammer toes, claw toe. Yeah, there's quite a long list, but much less common. Much less common. So, but generally, I'd always advise, if you can avoid an operation, that'd be the way to go. So padding areas, using protective silicone, seeing a podiatrist, maybe insoles, and then if those things don't work, then you could have. And there's some good keyhole solutions for correcting toe deformities.
Yeah. So you must see a lot of sports injuries like sprains, fractures, and breaks. I mean, I used to spend, with 3 boys every Sunday. I used to end up having some little toes, fractured or broken. I bet you see a lot of those. I mean, when you see kids, do you have to operate, or is that much, for those sort of sprains?
Yeah. So in terms of common sporting injuries, ankle sprain, and it might not even be due to sport, but ankle sprains are the most common. Lower limb, I think actually the probably most common trauma that presents to the emergency department. I don't know the figure, but it's tens of thousands a year. And it could be sport related, or it could be just wearing high heels and a few too many drinks, or just high heels. And you roll over, because when you wear a high heel, you're putting the ankle at a significant mechanical disadvantage because of the shape of the ankle. So as you bring your foot down, the ankle actually becomes narrower internally, and therefore, because it's narrower, it can move around more, and it's more likely to roll. So high heels, and I've not seen many ankle sprains recently in the past year due to high heels.
We're all wearing slippers all the time.
Yeah, exactly. Slipper injuries. Yeah, no ankle sprain, slipper injuries. Yeah, but often when you go to A&E, ankle sprains can be dismissed and completely wrongly so. And I see lots of patients, and it's a classic story. I went to A&E, had an X-ray, nothing broken. They just told me to get on with it. No boot, no crutches, no advice, no physio. And then patients come to me with at 3 months with persistent ankle pain because they've not had the correct treatment, or they've got instability where the ankle gives way, particularly on uneven surfaces, or they lack confidence in the ankle. So I think if you have an acute ankle sprain, it's really important to see a foot and ankle specialist to rule out a significant ankle injury, and to get treated properly, because the best will in the world, unfortunately, in the emergency department, they don't have necessarily the expertise all the time. And the treatment can range quite differently, from being in a boot for 4 weeks, sleeping in a boot for that period of time as well to make sure the ligaments tighten up correctly, or it could be physiotherapy for a mild sprain. So it's just worth getting checked out. In terms of children, as you asked, kids hardly ever, in my practice anyway, require or need surgery. They heal really well. You treat them, correctly, and it's very unusual for a child to require surgery. Thankfully, if there's a significant broken bone, then yes, of course. But for most foot and ankle conditions, it'll be a sprain probably, and they're treated readily with a boot and physiotherapy.
Yeah, and us sort of women who are perimenopausal or menopausal, we're obviously estrogen deficient. And so for those who are on HRT or taking estrogen, you're preventing, osteoarthritis. But for those who aren't, there are you hear a lot, especially when you're fully in menopause, of having a lot of bone breakages and that kind of thing. So I'm assuming estrogen, a lack of it, plays a part as well.
Yeah, so just to be clear on the terminology, so osteoarthritis would be a joint problem unrelated to the menopause.
Sorry, yeah.
Yeah, exactly.
Yeah.
Yeah, the osteoporosis or porous bone, effectively. Yeah, absolutely. So as you naturally get older, particularly in women who go through the menopause, those hormones have an impact on the quality of the bone, so it does become more porous. So that's why, as you get older, particularly women, you have an increased propensity for fractures, so like a wrist fracture or a hip fracture. So it's really important to do a few things. Don't smoke, and do load-bearing exercise. So if you're a swimmer, don't just do swimming, do something that's actually going to impact on the skeleton, because the skeleton's a living tissue. So if you put load through the skeleton, it will respond, and it will maintain its strength or get stronger. And that would be protective potentially for things like breaks and so forth in the future. And vitamin D is probably a really important vitamin to take. So I just started taking vitamin D myself. Never used to take any supplements at all. But I'm training to do an event, an Ironman, and I was concerned that the running was going to give me a stress fracture or something like that. And we know through the winter months, it's really common to be low in vitamin D. So you can take safely, without a blood test, up to 4,000 international units per day. So what you find in some patients who have been on steroids, for example, they take a tablet called Adcal D340. It's a common tablet to give. It's only got 400 international units. So we're talking about 10 times the amount that people are normally given. So it sounds like a lot, but actually it's safe, and you can look at the nice guidance on that as well, which supports it. So yeah, I personally take vitamin D, and I think it's really important through the winter to do that. And you can take it all year round, however, and that can be protective for things like stress fractures and other things called stress responses, particularly if you're doing lots of load-bearing exercise.
Yeah, I was going to ask you about other certain foods or supplements we should be taking, vitamins and minerals, or vitamin D. So we've actually got a great blog on our website about vitamin D as well. So we'll remember to mention that when people read the information you've given us. Are there any other certain foods or vitamins, minerals we should be aware of?
I think the most important thing is just to eat a nice, healthy, balanced diet. There's nothing specifically other than vitamin D that I'd recommend. Don't smoke is probably the other big one. And don't neglect a particular type of food. I mean, vegetarianism aside or veganism aside, I'm not talking about that necessarily, but I had a patient a few weeks ago, and this was unusual, by the way, but he ate the same 3 meals every day, which was highly unusual. But so we had to have a conversation about variety. And I think that's just important, to just have variety in your diet, and vitamin D.
So I wanted to ask you about certain occupations or lifestyle choices that, because I've got a lot of friends that took up running and maybe regretting it now in their 40s. I'm one of those. But there are yoga instructors, there are dancers. Who is more susceptible to certain conditions, and obviously what can they do to avoid them? I mean, you're doing Ironman. That's a perfect example of a lot of men I know at the moment.
So lifestyle has a big impact on our propensity to get injured. And yeah, perfect example. So I think before I talk a little bit about what I've been doing, being sedentary is not a great thing. So that's a lifestyle choice, not to do exercise. And so, yeah, that's not going to be great for your general health, your bones, muscles, tendons, ligaments, mental health, and everything else. So, yeah. So what you shouldn't then do, though, as we've discussed just earlier about, doing stuff in lockdown, is go from a sedentary lifestyle to suddenly walking 10 miles, even if it's just walking 5 miles, 10 miles a day, or suddenly going off and doing lots of running. It's all about adaptation. Like we talked about before about the plantar fascia and the Achilles. You've got to allow your time for your body to adapt to the stresses and strains going through it. So you've just got to be sensible. So the Count to 5K app, which you can download, is basic but great, because it just really eases you into into those sorts of activities. So don't take a leaf out of my book, the Foot and Ankle Surgeon's book. When I started running in September, I thought, okay, I've been cycling for about 10 years regularly. I'm pretty fit. Of course, I can go and run 10 miles. So I did, and it was fine, a bit achy. But I did it again, and I did it again. And in the third run, I had to stop. Guess what? My Achilles. I had significant pain in my Achilles and had to stop running for 2 months. And then I took a leaf out of my own book and started to go back to running, but much, much more gently. Nonetheless, guess what? My other Achilles then started hurting. So yeah, I've been through the mill with my own tendons, and I'm in my mid-40s, so I know exactly what it's like to, and I'm reasonably fit, but my tendons just weren't. So it's all about adaptation.
Yeah.
So talking about other professions, so I think probably yoga instructors probably have the least injuries that I've come across. They might have bunions, but they don't tend to get injured. I don't come and see me particularly. I have treated quite a few yoga instructors for their bunions, but in terms of an actual injury, we'll know. And then marathon runners, well, again, it's going back to adapting your tendons. But yeah, I do see a lot of running injuries. And again, it's all about, maladaptation. And then on the lifestyle choice of footwear, we talked already about bunions. Yeah. So if you want to wear narrow shoes and high heels, please go right ahead. But, your bunions are going to feel worse for it.
Yeah, absolutely. All right, before we wrap up, and I have a few questions I want to ask you. Can you just reassure people who are watching, because a lot of people I know through this, long year of pretty much, 3 lockdowns in the UK, that's for sure, that they will have neglected certain conditions during this pandemic, and obviously a lot of them are going to be anxious about going to hospital or to clinics. So how are you sort of keeping yourself COVID safe in your clinics, and obviously are there Zoom consultations?
Yeah. So my practice is in my 3 locations up and running, fully open for business, open for service, both for surgery as well as for consultations. And the hospitals in the private sector, as well as the NHS, of course, but in the private sector have been fantastic. So there's a whole range of different measures to make sure that everybody is safe, patients, staff. So all staff get screened for coronavirus. So I do a swab test every week, a PCR test. So I do my own swabs and they get sent in. All members of staff are getting screened to pick up those who may have it. The environments are set up for social distancing. So, you can't sit next to somebody else in a waiting room. You have to be, a seat or 2 apart. Everyone's given a fresh mask when they arrive. They have to hand sanitize. And those patients entering get screened as well. So you'll have your temperature chat. And in the London clinic, there's this very, very cool automated machine with a camera. It detects if you've got your mask on correctly. It also measures your temperature, and then it tells you whether you can actually enter into the building or not. And then vaccinations. So there's a rollout of vaccinations for those hospital staff as well. So most staff you'll find in hospital have had at least their first dose of vaccines. But for any patients who are not comfortable in coming for a face-to-face, absolutely I offer Zoom consultations, and I do those, I do Zooms, almost on a daily basis. But sometimes it is essential to actually examine the patient, and not always, but often it is. So there might be times when we do a Zoom initially and say, well, actually, I'd like you to come and come so I can actually examine and work out what's going on.
Yeah. All right. Well, that's very reassuring for everyone. Right. I'm going to ask you a couple of questions because I know we're running over, and then I might have to email you the rest. So sure. Jill Eckott says, my big toe has moved to under my next toe, which has made my gait different. There is now a white mark on the big toenail and on the underside of the next toe. Should I get this operated on to correct? For your information, I tried to have the big toe straightened 20 years ago as I could barely walk after playing badminton, and they said no. That's quite detailed.
So, well, whether you need surgery or not is a difficult question to answer. I think, as I said, I'd always try non-surgical solutions first before surgery, but it sounds like you've got a significant toe deformity. It may be post-traumatic if you had an injury, badminton all those years ago, and it kinked and then healed kinked, or it might be something like a bunion that's progressed over time. But if you're getting overlapping toes with your second toe is resting on the big toe, it's only going to progress and get worse. The toe is most likely going to be rubbing on the shoe. So I'd probably, certainly get an opinion sooner rather than later. Whether you need surgery is another matter, but I would get that checked out.
All right, thank you. Caroline Higham says, an ankle question. After a long 23-mile walk in September, my ankle bone was sore and has just got worse. I can't wear boots for very long over the bone as it hurts. The NHS phone physio said do calf raise to strengthen ligaments, but it isn't improving. Any advice? Oh, calf raises.
Well, difficult to know the exact location of where your pain is. I'd be concerned about, with a significant walk like 23 miles, if you don't regularly do that, it's something called a stress response. It's a precursor to a stress fracture. So a stress fracture is when you have the microarchitecture of the bone causes a crack in the bone. A stress response is leading up to that. So if you're pounding the streets for 23 miles, and your bones aren't used to that kind of stress, or if you've got low vitamin D coupled with that, then you can get inflammation within the bone, which is completely reversible, but can cause ongoing pain. It sounds like the NHS have given you advice to do Achilles tendon type exercises. So if your pain is at the back, on the big tendon on the back and the Achilles, then that might be relevant. But if it's at the front of the ankle or to the side, then it could be bone or another different tendon. So I would, if it's not cleared up since then, I would certainly get it checked out. It's now been 4, 5, 6 months now. So I would certainly get that checked out.
Angela Fletcher says, I've been told that I should think about treatment before the toes start crossing. I do not get any pain. Should I simply look into a spacer? So obviously her toes are overlapping a bit.
Yeah, it's so it's a common question I get asked when I see patients who see me who don't have significant symptoms. So significant is having an impact on your lifestyle, the things you enjoy doing, or the footwear you'd like to wear. So if you have 0 symptoms, sometimes it's quite hard to justify something like surgery, because surgery is about risk benefits. You have some small risks of surgery with hopefully a benefit to resolve the symptoms you're describing. If you have 0 symptoms, when you're just exposing yourself to those risks. However, then we're talking about sort of prophylactic surgery. Should one do surgery on a bunion that doesn't cause symptoms because it might get worse further down the line? It's a difficult one, and it's probably a personal choice. But it may also depend on the degree of your deformity. Because if the bunion is quite significant, it's only going to get worse. And we know that if you leave it, then you're going to get problems in the future. So it's probably better to get things sorted out at a certain point, but it's one of those conversations one has to have, and it's a personalized choice, and it's a discussion I have with the patient. But go and see somebody, get an opinion, and then decide.
All right, I'm going to ask one more question and then the rest we will leave. Charlotte Swindon, sometimes the 4th toe on my right foot is numb. I've had an x-ray, but nothing shows up. Any ideas?
So Morton's neuroma would give a numb toe. It's common, in addition, to have some discomfort under the sole of the foot around that area, rather than just a pure numb toe. So it could be Morton's neuroma. An x-ray is very unlikely going to show anything. We're talking about a nerve problem probably. So an ultrasound is what you would probably want to have to investigate that. If it's, there are other causes of numbness in the foot. If it's more general numbness of all the toes, then it could be, something as significant as diabetes. So again, worth getting checked out. But if it's an isolated 4th toe numbness, if the toe is straight and not kind of crooked underneath, then it might be a neuroma. If it's kind of a deformed toe, you can get a 4th curly toe, which curls under the 3rd toe. Then it might just be getting squished in the shoe, causing numbness. It's something as simple as that. So a spacer to straighten it. Yeah, you could certainly try that. You've got nothing to lose.
All right. Well, thank you, David, so much for coming in tonight. It's been really interesting and I've learned a lot. If anyone would like to book to see David, all the details are in our directory at lattelounge.co.uk on the website, or you can go direct to David's website, which is thebuniondoctor.com. Don't forget to follow David on Facebook and Instagram at The Bunion Doctor. This video is going to be available to rewatch on our YouTube channel. We're also going to have it embedded in a blog that David's written for us, and we're going to be showing it on all our social channels. So don't forget to follow us on Instagram at Lounge the Latte, Twitter at Lounge_Latte, and of course our amazing Facebook group for further updates. So thanks again, David, and thank you everyone else for joining us. See you soon. Take care.
Thanks, Katie, and thanks everybody. Bye-bye.
Bye.